by the name itself, we will actually try to understand here one thing, that these actually happens in air spaces along with the interstitial, which means to say they have the involvement of both the alveoli and also the lung parenchyma. So what actually happens is that these diseases are technically a little bit difficult to diagnose, or because they show up of radiographic features, which is mixed along with airspace and also the things that are related to interstitial lung diseases. For example, to say they might actually show up as alveolar fillings, and also may show up as interstitial related fibrosis or interstitial related ground glass opacities or something like that. We will see in the details when we get down to specific diseases. And now, actually, what they have is that they have both the features of airspace disease along with interstitial lung diseases, right? So one of the most important disease that we will be learning about in this kind of mixed pattern diseases is tuberculosis. And before we get that, we will also have to learn about some of the smaller disease, but potentially very important disease, which is also known as sarcoidosis, right? Sarcoidosis, we actually call this as alveolar sarcoidosis or pulmonary sarcoidosis, right? And this disease actually has got a very typical presentation. But first, let me tell you about the basic pathophysiology of sarcoidosis. What exactly is sarcoidosis? Sarcoidosis is generally, a multi-system disease that has got some kind of a non-caseating granulomatous reaction, which actually is happening because of the cell-mediated immunity, which means to say it has the pulmonary manifestations, it has the cardiac manifestations, it has got the gastrointestinal manifestations, along with central nervous system manifestations. So it has got multi-system involvement, but the diagnosis is generally made based on the pulmonary function, which has been completely compromised in such kind of patients. Well, the it has got a wide range of symptoms, why multiple system involvement, but the confirmation or the diagnosis is generally based on the chest X-ray, where we actually does the staging, which is actually called as the staging of the alveolar sarcoidosis, right? But what actually we see as the radiographic features here, we has, in addition to the bilateral hilar and paratracheal adenopathy, lymphadenopathy, which is the most important characteristic of this disease. And while the patients have this bilateral hilar and paratracheal, right paratracheal lymphadenopathy, they also would sometimes demonstrate interstitial lung disease patterns, right? Like mostly reticular fibrosis, reticulations, or pulmonary fibrosis along with honeycombings. Yes, it can be seen out. And the interstitial lung diseases is generally a mixture of both reticular and nodular component. So you have to remember one thing. So what can be a typical radiographic feature of a sarcoidosis patient is bilateral, hilar, and right paratracheal lymphadenopathy along with reticulonodular component, right? So, so like I was talking before, it has got 4 stages, right? From stage 0, let us say 5 stages. Okay, stage 0 to stage 4. And this progression actually tends to start with adenopathy, which is actually called as a stage 1, and then proceeds to a combination of both interstitial lung diseases and adenopathy, right? What we are talking about, the bilateral. Let us say we have a patient with only bilateral hilar lymphadenopathy. Yes, bilateral hilar lymphadenopathy generally, depending on the infection or depending on the focus, what actually happens is that, yes, we will be seeing generalized lymphadenopathy all over the body, right? Anywhere. Okay, let us say pulmonary infections. Yes, most of the times hilar lymph nodes are the ones that are involved. But how can we actually differentiate? Can we differentiate this patient if he's present in stage 1? Generally, no, it cannot be done, because we need to have some other pathological tests also that should confirm the presence of this disease. But however, you have to just remember here that stage 1 has got adenopathy. That is how it starts. And then it proceeds to a combination of both interstitial lung diseases, like what I was talking about, and then get into adenopathy also involved with it. Then we call it as stage 2. And then eventually it progresses down with the adenopathy that regresses while the interstitial lung disease remains. So what you actually see, how can I actually understand here, is that if I have different x-rays, let us say I have a patient of stage 1, stage 2, and stage 3. How can I actually differentiate these three people? Or let us say, even if the X-ray belongs to the same person, and I can see if the patient has been remitting out or if the patient has been progressing, how can I actually find? I can say that, okay, if I find a hilar lymphadenopathy, I mark it as stage 1, and then I have a combination of adenopathy along with interstitial lung disease patterns, particularly reticulonodular pattern. I call it as stage 2. And later on, after a few days, I take an X-ray once again, but this time I don't find any kind of adenopathy, or the adenopathy actually has been remitted, a little bit regressed in the sense reduced, and then, but still the patterns of the interstitial lung diseases have been remained out. So by this, I can actually understand that the patient has progressed down into the stage 4, and finally in stage 3, and finally in the stage 4, what eventually I find out is the patient has got complete pulmonary fibrosis. Okay, so this is what actually the staging is, that, but we need not really get into the close details of this one at this level, but still you actually understand that the sarcoidosis actually has got a pattern of both lymphadenopathies and interstitial lung diseases, and particularly it is reticulonodular pattern, right? And most of the patients with parenchymal lung diseases will generally undergo a complete resolution of the disease. Okay, now, let us try to understand what exactly is shown in this chest radiograph. So what actually we see here is that if you can look closely enough, okay, if you can look close enough, okay, this is the pulmonary artery, okay, this pulmonary artery, and along the pulmonary artery is that you see here, there is some other well demarcated oval density I can find out. It may not be visible, but still, yes, that is actually how I am imagining myself and thinking about the disease. You see here, this is the pulmonary artery, area of the pulmonary artery, bronchus intermedius is going along with it. And you see here, there is a white density, well demarcated, a round oval density of something around like 1.5 centimeters, greater than 1.5 centimeters. And also when I look on the opposite side also, I can actually see that the same place here. Generally, this is the pulmonary vein and this is the pulmonary artery, which is a comma shaped here, and this is the pulmonary vein and the pulmonary artery. But here, you see here, most of these places are actually now being silhouetted by some other presence, okay, which actually I came to understand from the anatomical knowledge that this is indeed a place of hilar lymph nodes. So now what I actually see here, you see here, this is the right hilar lymph node and this is the left hilar lymph node, and both of them actually suggest to me this kind of a density that he has got a bilateral hilar lymphadenopathy. And also at the same time, I can actually, when I'm going down along the lines of the superior vena cava, right, I can also see overlapping the obscuring the superior vena caval shadow. I can see that there is another oval density here along the dotted arrow mark here, and this one is the paratracheal lymph nodes. This is the paratracheal lymph node, the area. If you have a problem with the lymph node classification, just do one thing: browse back to your basic anatomical textbook and try to find out the groups of lymph nodes present down in the thorax. Okay, so this one, the shadow that is abetting the or obscuring the superior vena cava shadow, it is something that is actually being the paratracheal lymph node. So the first feature we already found out. Okay, so here we got the bilateral hilar lymphadenopathy on the both right side and the left side, along with the right-sided lymphadenopathy. Well, and then you also can see in the circular area here, there is a reticulonodular pattern, right? You see here small dots, and there is a crisscrossing things. All these crisscrossing things actually indicates that this patient has got also interstitial involvement. Now, could you tell me what could be the stage of this person? Is it stage 1, stage 2, or stage 3? So by the interpretation, what we just learned before is what could be the stage of this person, right? He's stage 2, obviously, right? Because there is an involvement of interstitial lung pattern along with the bilateral hilar lymphadenopathy, along with the right tracheal, paratracheal lymphadenopathy. So it clearly indicates that this patient is present, indeed present down within stage 2. But you see here, that is what I most of the people try to misinterpret. Most of the lymphadenopathies are. Now let me try to give you a clinical scenario. Okay, let me try to give you a clinical scenario so that you can actually understand what I am talking about. Let us say there is a patient of 45 years old, has been complaining of high grade fever for the last 3 days, and has got a mild grade cough with no respiratory distress, and he hasn't got any kind of a prescription or no hospitalization history, and he came to an OP clinic. Now, when you took a next day, actually you came to find out that there is a unilateral hilar lymphadenopathy. Now, this is case 1. Then next, the case 2, let us try to say a person of 35-year-old male has been complaining of a chest distress along with the mild grade dyspnea, okay, along with mild grade dyspnea, and also has got intermittent fever for the last 3 months. Intermittent fever for the last 3 months. Well, he has been hospitalized for one time, and he has got a, you know, something around like 2 cycles of antibiotics. He has received some kind of antibiotic therapy, and but still now he has come to OP clinic again with some almost similar symptoms. Now, actually tell me what could be the diagnosis of this case 1 and case 2. So can you eventually say that which one is sarcoidosis and which one is not sarcoidosis? How can you actually see? Did you understand my question? Okay, let me tell once again the cases. The case 1 is okay, a person of 45-year-old male has come down to an OP clinic with a complaint of fever for the last 3 days with no respiratory distress and complaints of mild grade cough. And on an X-ray, we came to find out that there is a unilateral lymphadenopathy. The second person is the 35-year-old male who has been complaining of respiratory distress along with mild grade dyspnea for the last 3 months, and also have had an episodes of intermittent fever. And he has a history of hospitalization, and he has also been given antibiotics. But now he comes down to the hospital again with the same kind of complaints. So which patient is sarcoidosis and which patient isn't? Is my question clear for everybody? Which one is sarcoidosis? Shafiq, patient 1 is sarcoidosis? Okay, second patient is sarcoidosis. Yeah, because I had given you a very, very classical and typical presentation. But what about the patient 1? What about the patient 1? Why can't you actually try to think of sarcoidosis in the patient number 1? Why are we not thinking about it there? Yes, first thing, yes, it is unilateral lymphadenopathy. Yes, obviously, that is what I have been saying. A mild grade respiratory infection like a pneumonia or something around like a, mild grade tuberculosis, primary tuberculosis will eventually come down as a hilar lymphadenopathy. So you have to remember one, there is a diagnostic criteria that bilateral hilar lymphadenopathy along with the right pretracheal lymphadenopathy is exactly stage 1. But since this patient, the patient number 1 has got only unilateral hilar lymphadenopathy, so that's the reason I cannot classify him as sarcoidosis. So you have to understand the takeaway point here is that every lymphadenopathy technically does not indicate that the patient has got some kind of infection, or also does not indicate that the patient has got a very, very prominent progressive disease like sarcoidosis. See, any kind of a disease for analysis in radiology should have some kind of an associated symptoms with it, and also it should be proven down along with the radiographic features of that individual. Okay, you want me to repeat, Reshma? Do you want me to repeat it? Okay. Do you want me to repeat along with the case histories, or do you want me to just repeat the scenarios? Okay. See, the answer for the first patient is not sarcoidosis. The first evidence I came to find out is that it is the lymphadenopathy, which is unilateral. We did not find out bilateral hilar lymphadenopathy along with right paratracheal lymphadenopathy. We did not find it. Only if we find bilateral hilar lymphadenopathy along with right paratracheal lymphadenopathy, yes, it is stage 1 sarcoidosis. So the patient 1 has got only unilateral lymphadenopathy. That's the reason it is not sarcoidosis. You also have to remember one thing, that every infection or any inflammatory condition may give you lymphadenopathy, but it does not indicate a very, very progressive disease like sarcoidosis. Did you understand now? Is it clear, Reshman? No? And how we are actually going to differentiate these patients is just try to observe, just try to understand with his associated symptoms. Are there any other associated symptoms? Are there any extrapulmonary manifestations? Are there any kind of symptoms that are coming related to gastrointestinal system, central nervous system, or something like that? If you can remember in our general principle class on the first day, I have been showing up an MRI of a patient, and I was telling that, okay, this patient is suffering from neurosarcoidosis. Do you remember that, guys? When we were trying to learn about the imaging modality and, you know, prescription of an MRI, we were trying to deal about a patient with neurosarcoidosis. So, extrapulmonary manifestations on radiology, like that is involved down in the brain, and pulmonary manifestations on a chest x-ray, both of them correlating together, we can actually picturize the patient as if he's suffering from sarcoidosis. That is how we actually make out the diagnosis of these patients. But severely, we consider chest radiograph to be confirmatory, because this is a diagnostic. This diagnostic chest x-ray is very, very highly diagnostic in diagnosis of sarcoidosis, because we have got, it is always necessary that the pulmonary manifestations of this person has got different stages, which actually indicates the progression of the disease. So by this we can actually know the clinical scenarios, how the patient has been presenting it, and the way also we will actually be treating the patient, right? Okay, but we will not go into the treatment pattern. Now let's try to understand what exactly is tuberculosis. But before I go into tuberculosis, let me give you a very, very good information that any kind of a patient who has got frequent hospitalization, and I have also been talking about sarcoidosis, that it is a cell-mediated immunity-based caseating granulomatous, non-caseating granulomatous reaction, right? So, which means to say it is an immunocompromised patient. And also, you have to understand, if you have learned about the pathophysiology of sarcoidosis in your basic classes, actually, it suggests that most of the sarcoidosis patients has also got secondary opportunistic infections, out of which tuberculosis is the first prevailing manifestation. Prevalence of pulmonary tuberculosis in patients in sarcoidosis is high. Don't ever forget this thing. And if you are suspecting a patient, if he is tuberculosis, you also think maybe he could have got, okay, maybe he could have got sarcoidosis. Maybe the reason for pulmonary tuberculosis could be sarcoidosis. Now, let me ask you a question. What are the risk factors of tuberculosis? What did you learn in your basic classes? What are the risk factors of tuberculosis? What are the risk factors of pulmonary tuberculosis? No, that is the mode of transmission, Ravendra. Mode of transmission is droplets. Martin, okay. Man, we have got so many mixed answers here. Okay, let me clear off all once and for all. Let me clear all of your doubts and all of your misconceptions what you have been learning it from your basic classes. Yes, Dravendra, droplet infections, yes, is the sole mode of transmission of tuberculosis. Okay, mode of transmission from tuberculosis. Next, I will talk about smoking in the last. The first important risk factor is that the patient is being exposed to Mycobacterium tuberculosis. That's the first important risk factor. Somebody, see, any kind of a tuberculosis patient will have a very typical presentation. The patient has a history of living around the people of tuberculosis. He comes down from tropical countries like India, tropical countries like Malaysia, Singapore, and Indonesia, Philippines, Africa, South America. He is coming down from tropical countries where the prevalence of Mycobacterium tuberculosis is high. That's first thing. And somebody of the family member has got a tuberculosis infection, or he is living in the vicinity of tuberculosis. The second risk factor is overpopulation. Person living down eating. Okay, let us say the most important problem with tuberculosis is actually community spread. The same thing that is has happening with the coronavirus right now. It is the community spread because it spreads down through droplet infections. And I think here right now we have been talking about very seriously about these quarantine protocols, right? Quarantine, another name for this quarantine is also we are calling it as social distancing, and the minimum distance that is maintained by a person from another person is generally we call it we are keeping it a distance of 1 meter. Why are we putting it 1 meter? Because all these viruses and especially Mycobacterium tuberculosis will actually be surfaced onto the other person, and the other person is at high risk of getting down the infection where the tuberculous bacteria is absorbed through mucous membranes. Did you get it? Even the coronavirus, yes, spreads down the same way. And if adequate distance has been maintained, yes, there is reduced risk of droplet transmission, right? Well, yeah, I mean, you are correct with that one. And you see here all the other things that people have been mentioning, like smoking, or the person like with drug abuse, or the person with other manifestations like silicosis and bacterial infections. Yes, they will be immunocompromised, and eventually when there is immunocompromise, cell mediated immunity is decreased, and they are liable to develop pulmonary tuberculosis if they are living in the area of prevalence. See, tuberculosis might develop in a patient where there is a prevalence in a society. Now you see here we have got so many Indians and Africans sitting in this class. Now you tell me, how many of you people have pulmonary tuberculosis? Is there any person in you out of 150 students sitting in this class? Tell me, is there any kind of a person suffering from tuberculosis? Yes, no? See, now it is contradicting my answer. Yes or no? We are We are all living. No, you see, statistically maybe, but I will tell you why actually these statistics are very important here. Because statistics actually show that yes, even though you are trying to live down in an area of highly prevalent tuberculosis, but still a person will not develop tuberculosis because it is dependent not on the prevalence rate or the distribution rate of the disease. It is actually depend upon the immune capacity of the individual. Bacterial infections, do bacterial infections have carriers, latent carriers or something like that? Exactly. You see here, we may be carriers of pulmonary tuberculosis, but every person getting positive on a pulmonary tuberculin test does not indicate that you are suffering from pulmonary tuberculosis. Because you see here, since it is a cell-mediated immunity and we were sensitized with Mycobacterium tuberculosis, and you are trying to find out the induration on the piperacillin tuberculin test, every kind of induration increase does not indicate that you are a patient of pulmonary tuberculosis. And the progression of the pulmonary tuberculosis usually depends on what? It depends on your immune capacity. If you have other comorbidities like alcoholism, comorbidities like smoking, immunocompromised diseases like AIDS, HIV, and you have hepatitis, all these infections and a history of long-standing diseases, chronic smoking, all these people will eventually develop from pulmonary primary tuberculosis down to secondary tuberculosis, right? So that's the reason we do not have symptomatic pulmonary tuberculosis. We may be positive for tuberculosis, but it does not indicate that we are infectious. Is that clear now, Martin? Right? Smoking is one of the associated risk factors with tuberculosis because it is giving out the interstitial manifestation. And as the interstitium gets weakened, yes, the patient eventually, if he has been exposed to pulmonary tuberculosis, will eventually get down into the second stages later on. So that's the reason smoking is considered down as the risk factor for tuberculosis. But speaking of which, pulmonary tuberculosis main primary risk factor is living out in the area of prevalence and being exposed down to tuberculosis within a dense population and living within the close vicinity of a patient with tuberculosis. And most of the poor countries, developing nations, yes, we have a high dense of population where 5 to 10 people are living down in a single room. And if somebody has got a tuberculosis and every person has got poverty, he is not having adequate nutrition and he is not well hygienic and he is completely, not following any kind of social distancing. And what happens eventually, this patient slowly gets the most viral and the bacterial load. And if he has got so much bacterial load, he will develop these symptoms of pulmonary tuberculosis. That is the reason you see here, even in coronavirus thing, we are talking about the viral load. Not maybe every person has already been exposed to coronavirus if you are living down in the red zone. But the viral load, let us say I have got only 5 viruses on my body and my immune system has completely removed them. But let us say I have got 5 million viruses on my body. No, my immune system will not be able to completely remove them. Maybe it will remove something around like 1 million virus, but still 4 million virus are pending. And that is the one actually giving me down the disease. Did you understand why coronavirus is community spreading now? And not everybody that has been exposed to corona does not develop symptoms, may be latently positive, but still it is actually happening because of the viral load. That is the same way how pulmonary tuberculosis is also progressing. But forget about all the pathology thing. We are more concerned with the radiographic features. Now let me talk about the radiographic features. So what actually happens is that, okay, let us try to look at the basic statistics here. Third, up to a third of the world's population is believed to have been infected with Mycobacterium tuberculosis. Being infected doesn't necessarily mean to say that you have symptoms. It means to say pulmonary tuberculosis has got three stages: asymptomatic patients, subacute patients, asymptomatic or subacute patients, and then the patients with peculiar symptoms and the patients with close to death. Okay, that is what are the four stages of pulmonary tuberculosis are. But having infection doesn't necessarily mean to say that you are suffering from tuberculosis. Having symptoms is called as tuberculosis in clinical way. But definition wise, yes, infected with Mycobacterium tuberculosis obviously means to say you have tuberculosis, right? While the incidence of TB is decreasing in the United States, yes, it has always been increasing and it is still present. It is still vastly present and prevalent in developing countries, especially countries like Africa, India, Philippines, Singapore, and Malaysia have got high cases of tuberculosis. And most infections, you remember, most infections has no symptoms, but 1 or 10 patients go down into active tuberculosis. So that's the reason whenever you are trying to confirm a patient with active tuberculosis and inactive tuberculosis, what are we going to do? We are going to go for a gold standard test, which obviously is the sputum culture, right? Sputum examination. Okay, sputum examination is the confirmatory or the gold standard uh, test for Sadaf. I cannot find Sadaf here. Sadaf, you are already inside. Why should I call you again? You are already inside the classroom, right? Okay, acid fasting staining, yes, we call it, right? Okay, did you understand now? Is it everything clear now, right? Okay. Maybe what you have learned down in your basic classes may be a little contradictory to this, but actually in the clinical scenarios, we actually, do it like this, that diagnosis. Okay, we will talk about Quimsil skin test later on. Reshma, yes, that is a very good point. But let me complete off the radiographic features first. Okay, relatively few patients with primary tuberculosis have clinical manifestations. Now, somebody tell me what is the clinical presentation or the clinical symptoms of pulmonary tuberculosis? Reshman agrees. The one actually what you were talking about is, which is a skin test that is actually done to detect the sarcoidosis. It is actually called as Quim test, or also known as the Quim-Silsbach test. Okay, it is a diagnostic test for finding out whose patients could have developed sarcoidosis. Okay, right. Well, this is a very yes, people, yes, I think you have got a lot of symptoms. I think you know very well about tuberculosis. You see here, the most important and diagnostic first criteria that a person should have in tuberculosis is productive sputum. Productive sputum that has been aggravating for the last 15 days. More than 15 days, okay, a persistent cough with productive sputum for more than 15 days is a first suspicion, and then associated things like high grade fever, hyperpyrexia, night sweats, weight loss are the ones that are okay, loss of appetite. Yes, all of them are some of the diagnostic criteria for a diagnosis of tuberculosis. Weak and clammy skin, no, not exactly. They are the secondary criteria. Chest pain, not exactly. Chest pain will be coming down in a tuberculosis patient unless he has not developed the complications of tuberculosis. Dr. Bling, is that clear? chest pain is not developed in a tuberculosis in the early stages of primary tuberculosis and secondary tuberculosis. It will be having in the tertiary tuberculosis in a patient with complications, if the patient has developed the complications. While we are talking about the radiographic features, I will come down to the chest pain once again. But still, first remember the main important diagnostic criteria: a cough that has been persistent for more than 15 days, and then the patient has a production of sputum, and then the patient has got hyperpyrexia, night sweats, weight loss, and have got severe loss of malaise and lethargy that has been persistent for so many days. And indeed, yes, he has to be coming down from a area of highly prevalent tuberculosis. Then you check out for the comorbidities, then yes. Okay, now let us say if a patient is coming down with this kind of a typical history. Let me give you a scenario. If this kind of a person, okay, a 65-year-old male who has been working down as a textile worker, right? He has been working in a textile factory, and he has been complaining of a high-grade fever, mild-grade night sweats, along with the loss of weight and loss of appetite, and he has got lethargy, and he seems to be sick, and he has productive sputum. Now comes down to your hospital. Can we call this as tuberculosis? He's from US, okay? Why not? It fits your diagnostic criteria, right? Atul Pathak, you cannot say maybe. You cannot say maybe. You have to decide if you have to do a piperacillin tuberculin test in that patient or not. First decide. Don't suspect. What do you want to check for? Use your brains. Use your brains. No, I don't want to do my sputum test. Then what are you going to do? Okay, exactly. You see here, you will look for a radiograph, but clinically speaking, do you still believe that this patient has got tuberculosis? Is there any evidence from your clinical knowledge saying that this patient has got tuberculosis? And you tell me that specific point, then yes, we will move into chest radiographs. The clinical point, actually, what I remember here when I'm trying to say here, yes, the patient has productive cough, and I'm thinking about the patterns of productive cough, and I am also looking at the fever patterns and history of infection or living down into area and migrating down to tropical countries or being with the vicinity, because such kind of a typical presentation of this patient that I have been talking about mostly may be related down to cotton related disease, which is actually called as byssinosis. Okay, right? The condition is an interstitial lung disease, which is an occupational lung disease, interstitial occupational lung disease, which is called as byssinosis. So that's the reason it is not, even though the presentation is clinically almost relates down to the tuberculosis, but I cannot mark my patient as tuberculosis. So how can I confirm? I do a chest radiograph. Then let us look at the chest radiograph. So what can I find in chest radiograph of a primary TB patient is that the upper lobes are affects the upper lobe slightly more than the lower lobes, and then also it produces airspace disease that may be associated with ipsilateral hilar lymphadenopathy. And some are times you have large and often unilateral pleural effusions in adults, right? Okay, see, the first thing what we actually try to understand in a primary tuberculosis patient is that I think we have to get back down to a little bit of your pathology relations. Okay, when the tuberculosis bacteria enters down into your body, natural killer cells start place, and then macrophages are activated, then T helper cells are activated, then finally producing a reaction called as granulomatous reaction, which is the basic pathophysiological mechanism of phagocytosis. Simple, right? Necrosis is being activated. If the complete cell is dead, we call it as necrosis. Or let us say apoptosis is triggered and then the blood circulation is also stopped, then actually eventually necrosis takes place. But in first time, a small bacterial load has come down and macrophages have been started down doing phagocytosis. It will actually cause a granulomatous reaction. And the presence of this granulomatous reaction usually happens in the upper lobes and generally happens in the upper lobes. Doesn't matter. Before, we used to think that tuberculosis mostly happens in the right lobes, but right now it is not exactly correct. We can say it is actually happening down in the upper lobes. It can be on the left side, it can be on the right side. Before, we also used to think that this patients are actually have got, if you see some kind of a Gons focus, or if you see a granulomatous kind of lesion in the right upper lobe, you call it tuberculosis. But right now that criteria is gone. Any kind of a Gons focus present down either in the left lung or the right lung, both of them indicates that the person has got tuberculosis, and it is actually happening because of the primary granulomatous reaction that is actually happening because of presence of macrophages. So that is the first characteristic feature that we see it. And it is happening down in the upper lobes because, okay, what is the tuberculosis? How do you classify tuberculosis? Anaerobic bacteria, aerobic bacteria, acid fast bacillus, is it aerobic or anaerobic? Okay. Maybe let me try to, man, is that so? Aman, do you remember aerobic bacteria and anaerobic bacteria just because it is happening in lungs or if it is happening in stomach? You're wrong, Aman. Okay, then do one thing. Let me give you a let me give you a homework. Try to find out the classification of tuberculosis. Try to find out what exactly is it, aerobic bacteria, anaerobic bacteria. Get back down to your pathology textbook and try to learn about the complete pathophysiology of tuberculosis. Right? Okay. Aerobic bacteria, that's fine. But still, if it is in lungs, it doesn't necessarily mean to say aerobic bacteria. We have aerobic bacteria even in lungs. We have anaerobic bacteria even in lungs. So that's not how you remember that. Fine. See, the first thing, we actually have to see that there is a mixed pattern. And what is the thing? Which side you have got that granulomatous reaction, that is the side you are actually having the hilar lymphadenopathy. Let us say if the Gons focus is seen down in your right lung, there should be right hilar lymphadenopathy. And what is the criteria for lymphadenopathy? Lymphadenopathy is visible on a chest X-ray only if the gland is more than, okay, remember, if the gland is more than 1.5 centimeters. Always remember, lymph nodes are not seen on a chest X-ray. Only if it is greater than 1.5 centimeters, it starts getting visible on a chest X-ray. So what is the criteria for finding out if the patient has lymphadenopathy or not? Measure the lymph node that you look on the X-ray and say if there is a lymphadenopathy or not. So any lymph node that has got a diameter greater than 1.5 centimeter is meant to be enlarged. Enlarged hilar lymph node along with the focus on the right side indicates that the patient is having tuberculosis. So ipsilateral hilar adenopathy along with the same side of pulmonary lesion is indicates that he has tuberculosis. And you actually also see that unilateral pleural effusions are more common in these patients, especially in adults. And also cavitation generally do not happen in primary tuberculosis. If you see cavitation in a patient, you will be talking about secondary tuberculosis or third grade tuberculosis, but cavitation is not present in primary tuberculosis. It is actually happening because the patient did not had went down into a completely cacheating and liquefactive necrosis. The patient did not get into that stage. Only granulomatous reaction happened. After granulomatous reaction, and completely if it is progressing, yes, the patient next enters down into the pathophysiological reaction of necrosis. If you have did not learn all these things in your basic pathophysiological classes, please go back and try to learn one again, because in primary tuberculosis we will not have necrosis reaction, we will have a granulomatous reaction, and that's the reason there will be no cavitation. It is just the phagocytosis that has been activated. And now you see here, Shubham, why are you talking about other parts of the body too? We haven't come down it, we are just still in the lungs. Please wait for some time, okay? I will talk. Yeah, you are correct. And you see here, there is a prominence in the left hilum. You see here, there is a very, see here, there is a very small opacity that is present down in the upper lobe of the left lung. And you see here along the same way, there is a small opacity again that is present down here on the left side of the heart along the aortic shadow. You can see a very clear demarcation. So this here I see some kind of an opacity, well demarcated opacity, hazy density, and we can technically also call it as a patchy density. Okay, a single focal patchy density that is present down on the left upper lobe along with lymphadenopathy on the left side indicates that this patient is suffering from primary tuberculosis. Now this is actually called as a Gons focus. This is a Gons focus. Got it? Remember, that is a Gons focus, which actually suggests that the patient has only granulomatous reaction. Got it? But now eventually, and then here also the same thing you see here, unilateral uh, hilar adenopathy may be only the manifestation of primary infection with mycobacterium tuberculosis, especially if it is happening down in children. But this patient has to have a clear history, okay? And the patient should be severely compromised. The patient should be living in the area of prevalence of tuberculosis. He should be malnourished and other things. Yes, in that time only primary infection can be suspected. Now that's the reason any kind of a child coming down with unilateral lymphadenopathy has to be evaluated for two things. He has to be evaluated for community acquired, he has to be evaluated for atypical pneumonias and infectious pneumonitis and also tuberculosis, so that we can make sure to stop the progression of the disease beforehand itself. Now, you tell me, there is a difference between the treatment of tuberculosis patients and pneumonia patients, right? What drugs we actually give for a patient with staphylococcal pneumonia, streptococcus pneumonia or staphylococcus pneumonia? Reshma agrees. Where are you finding all these things? Simon's focus. Yeah, I will teach you. Okay, just wait. Let me complete the basic things. What is the treatment for tuberculosis and pneumonia? Right, okay. Yes, there are millions of antibiotics. Which antibiotic will you give, Shabi? Broad spectrum antibiotics. There are so many broad spectrum antibiotics. And can you just tell me some names? Sandra? Broad spectrum antibiotics. Do you like the same thing down on your prescription? Say that, okay, give the patient broad spectrum antibiotics. Is that way you write a prescription? So you need to remember the names too. CPCV. Man, I'm living in US. What is CPCV, man? Maybe you are talking about cefixime with potassium clavulanate combination. Remember the scientific names first, then you can go for brand names. Okay. See, broad spectrum antibiotics. Typically, if a patient presenting up with pneumonia, we will be giving down fluoroquinolones like ciprofloxacin, norfloxacin, and ofloxacin. Then we will also be giving out some other drugs like amoxicillin, penicillins, and then we also give generation 4 cephalosporins. All of them are broad spectrum antibiotics. Fluoroquinolones are the drug of choice for pneumonias, whereas tuberculosis is being treated by anti-tubercular drugs, which we actually call as INZH. Isoniazid, pyranezamide, ethambutol, and rifampicin. Isoniazid, isoniazid, rifampicin, pyrazinamide, and ethambutol are the drugs that are given down for tuberculosis. But for resistant tuberculosis, we are going to add levofloxacin and streptomycin. Okay, anti-tubercular drugs, we are going to add resistant tuberculosis. We are going to add levofloxacin and streptomycin. Anti-tubercular drugs, what are the drugs we actually give? We give rifampicin, isoniazid, pyrazinamide, and ethambutol. And the therapy that is actually used is called as DOTS therapy. DOTS therapy is nothing but directly observed treatment strategy. Directly observed treatment strategy. Okay, strategy. And why actually I'm talking about this information? Actually, now let us say if I have given some kind of a drug to this patient with some kind of a focus that has been seen down in his left lung. If I have given a tubercular medicine to this guy and I ask the patient to come back within 3 weeks, and if I see and I repeat the chest x-ray once again, and if this focus is gone, I can technically make self my sure that yes, the patient has been with tuberculosis. But if the focuses are not being reduced, or let us say if the patient has been given down some kind of a fluoroquinolone, yes, the focus has been reduced, but still it came back once again. On the third week, the patient came back with much more severe symptoms, which means to say, again, even the treatment is going to classify me and tell that if the patient has been suffering from pneumonia or tuberculosis. Did you understand this logic? Levofloxacin is also a fluoroquinolone. If I have given the patient down a levofloxacin drug, patient has remitted for some point of time, but still came back with a progressive disease more. Then eventually I understand, yes, the patient is getting down with primary tuberculosis and developing down into secondary tuberculosis. But if it is pneumonia, yes, it will be gone, and lymphadenopathy will be gone too. See, that is how I do it. This is how I use the radiological images in the management also for tuberculosis. And in some of the patients, what actually happens is that you will be having pleural effusions. Look at this patient. It is a very typical presentation. There is a complete obscuring white opacity of the of the left renal cardiophrenic recess along with a curve like line, and this one is actually called as the meniscus. Okay, there is a opacity obscuring the shadow of the lower lobes of the lungs. The cardiophrenic recess is completely obscured, it is not seen. And see, it means to say that the patient has got pleural effusion. This is not related to pneumonia of the lower lobes because it will not have a regular borders, it will have a hazy density, but you look at this patient is not having hazy densities. It is well demarcated. And now you see here, there is a curve here. This curve is actually indicating the fluid level. So by this, I actually understand that there is a pleural effusion. We will talk about this pleural effusion, but still you understand tuberculosis patients, one of the most important complication in a tuberculosis patient is pleural effusion, right? It can happen either in primary or post-primary forms of the disease, but are common in primary form. Uh, if you read about the pathophysiology of the tuberculosis, yes, you will understand why there is a effusion. But for radiological wise, just remember how is primary tuberculosis manifest as. Yes, sometimes it can also produce tuberculosis effusion. Okay, right. Then you see here, they are usually unilateral and they tend to loculate. They loculate, and loculate in the sense they are going to get down into the dependent parts of the thorax, which means to say because the fluid is completely pulled down due to gravitational force, and that's the reason we can see here that way. And sometimes, yes, they can also be seen down in the fissures. So insisted pleural effusions along with the lower complete filling up of the fluid in the cardiophrenic recesses is a characteristic feature of tuberculosis. Right. Now, if there is a patient with unilateral effusion, if there is a unilateral effusion, it is actually means to say that the patient, what's the first thing that you have to suspect? Yes, maybe he could have had tuberculosis. Every effusion is not tuberculosis, but still, what is the first thing that has to come down in your mind? You have to think about tuberculosis. Okay. And they are relatively symptomatic, relatively completely asymptomatic, symptom free, right? And then you see here, what about the other tuberculosis? What about the secondary tuberculosis if it has been reactivated? Reactivated tuberculosis, the first important feature is cavitation. Okay, I will show you the cavitation, then we will understand. And first, remember the basic radiographic features. A cavity usually is thin walled. Remember, cavitation, it is thin walled and has a smooth inner margin with no air fluid level. Okay, it is thin walled, has a smooth inner margin and no air fluid level. Okay, right? Then, but abscess is entirely different from a cavity. Remember this, we will talk about the abscess things later on. Okay, so now this actually indicates that there is no air fluid level, which means to say the patient is only having liquefactive necrosis. Caseating granulomatous necrosis did not happen in these patients yet. The patient is just present with a liquefactive reaction, right? Okay, so how we can differentiate the cavity? It is a thin walled and has got a smooth inner margin. And post-primary tuberculosis almost always affects the apical and posterior segments of the upper lobes or the superior segments of the lower lobes. Remember, apical posterior segments of the upper lobes are the superior segments of the lower lobes. Bilateral upper lobe disease is very common, right? It can be seen in the both sides of the upper lobes, or it can be seen in the apical posterior segments of the upper lobes, or in the superior segments of the lower lobes. All the places where there is a high aeration, that is the place where you can see tuberculosis bacterial focus. Cavity do not have air fluid level. Okay, cavity will not have air fluid level. Abscess will have air fluid level. We will talk about this one. Abscess will have air fluid level. Cavities do not have it. Okay, right. Now, you see here, it can actually spread. Mycobacterium tuberculosis will be spreading down from one part of the lung, one segment of the lung to the other parts of the lungs, other lobes of the lungs. It can start from right side and then go down, eventually go down to the left side. It actually, what happens is that the granulomatous reaction will will be slowly, uh, just give me a second. I think this girl has some kind of a problem. Right. And this one actually comes down with transbronchial spread. First thing you have to remember, if it is happening in one part of the lung, one segment of the lung, it will eventually go down to the other parts of the lungs. First, because of aeration spread, which is actually called as transbronchial spread. Then from one lung to the other lung, it is going actually because of the hematogenous spread. Then it is going down from one uh, part of the body to the other part of the body, which means to say again happening because of hematogenous spread. And if it is happening, if the tuberculosis is happening in the other parts of the body, we call it as extrapulmonary tuberculosis. So extrapulmonary tuberculosis is a most important feature of post-primary tuberculosis. Extrapulmonary manifestations are there. It can spread down to intestines, which is called as intestinal tuberculosis. It can spread down to the uterus and the ovaries, which is actually called as Mead syndrome. It can also spread down to the bones, which is called as Pott's disease, right? Tuberculosis of the spine is called as Pott's disease. If it can also spread down to the large bones, which is called as osteopathic tuberculosis, right? There are so many extrapulmonary manifestations, but it is actually happening. How does it start? It starts with transbronchial spread. So now, if any kind of a lesion that you found out before in the previous x-ray, now there is a lot of patch opacities that are present down in the second lobes in the same patient. Now you actually first you have to think about Mycobacterium tuberculosis. And healing of the post-primary tuberculosis generally occurs with a fibrosis and a retraction. Granulomatous reaction, every granulomatous reaction or an inflammatory reaction heals. And how is healing happening? Healing is happening because of fibrosis or keratinosis. If it is on the skin, we call it as keratinization. If it is happening in the other parts of the body, we call it as fibrosis. So how healing post-primary tuberculosis will eventually show up? Fibrosis. And how does a fibrosis look like? Something like interstitial manifestation, which you see here. Now this is a tuberculous cavity. You see here it has got a well-defined round shape with a wall along with a hypodensity in the center. So this one is the characteristic feature of a cavity. A thin-walled, well-defined opacity along with central radiolucency is called as a cavity. Remember, well-defined radio opacity with a thin wall along with central radiolucency is called as a cavity, and it happens in post-primary tuberculosis. Did you understand? Now, these patients, actually, if there is a presence of a cavity, it means to say there is activation of tuberculosis. So active tuberculosis, you have to always suspect if there is a cavity, there is an active tuberculosis. Because what happens is that if the cavity is going to break down or it has entered down into a progression of cavity just because the tuberculosis is causing granulomatous reactions in them, which means to say that tuberculosis is active. So cavity indicates what? Activity of the tuberculous bacteria, right? So how can I define it? It is a well-defined it is a well-defined opacity mass with the central radiolucency. Okay, cavities can be smaller, cavities can be bigger, cavities can be one, cavities can be so many, right? But generally, in first post primary tuberculosis with mild grade reactivation, yes, maybe some kind of a single cavity will be seen. But in so many patients, eventually this will become more bigger as the bacteria spreads in this region. Get it? So bigger cavities can also be seen, small cavities can also be seen. One cavity can be seen, so many cavities can be seen, right? And now you see here, eventually the patient will have cavitatory pneumonia, all the regions that have been involved with the cavitations, and now they all come together and form an opacity. And now you see here there is a large opacity with heterogeneous densities in between. Now this indicates it is a cavitary pneumonia, which actually suggests that it is indeed an interstitial along with airspace pattern. And you see here there is also and you see here there is also one black lucency here. Numerous cavities are present. This radiolucencies actually indicates that there are cavities. And you see here there is a cavitary pneumonia, one big cavity along with complete collapse of the interstitium there. So, and alveoli are filled up with inflammatory fluid. And what is this inflammatory fluid here? What is this inflammatory fluid here? Is it water or is it something else? Is it water or something else? Pus. See, now technically mucus with along with pus. So that's the reason. Also dead cells. Yes, true. So that's the reason this person will have high productive sputum, and the sputum is yellow in color. Did you get it? So even with the symptom, so if a patient is presenting up with a chronic productive sputum, I should be expecting to look down at cavities in the X-ray. Did you get it? I should be expecting down with so much consolidation and interstitial in this patient. Yes, did you understand how I am relating his symptoms to the expectant radiographic features and how I am actually making out the staging of this disease? This is very complicated. Try to learn, try to understand it 2 or 3 times. I will take it very, very slow. If you do not understand, tell me, I will be much more slower. Do not ever ignore tuberculosis because it is a deadly disease. If it has been progressed, death is evident in these patients. You cannot prevent death. Right? Okay. Now, exactly, that is what I have been saying. The extension, the shadow that has been extension is nothing indicates that air space and interstitium are both involved here. Okay, it is a consolidative pneumonic-like feature. Okay, is it clear, Nashra? It is the both alveoli along with the interstitium that have been filled up. Okay, alveoli are filled up with caseating reactions, pus. Okay, and then interstitium also has been collapsed, right? And which eventually formed a cavity. So that will show up as a opaque shadow. Okay, and now you also have to understand, by this I came to understand another complication, that atelectasis and volume loss is also a characteristic feature of primary TB, sorry, post-primary TB, right? Did you get it? So all of them, pleural effusions, cavitations, abscesses, atelectasis, fibrosis, all of them characteristic features of pulmonary tuberculosis, stage 2 and stage 3. Okay, secondary tuberculosis, or you eventually generally call them as post-primary tuberculosis. Remember it as simple primary tuberculosis and post-primary tuberculosis. Okay, then we will also have, as the disease progress. Yeah, sure, I'm almost done. I'm almost done. Just give me 5 minutes and I will have a break. Sure. Okay, and you see here, as the disease progresses, there will be much more interstitium actually broken down and broken down. Okay, and that's the reason you see here, I also see that all the bronchuses have been completely dilated. Now all the bronchuses are looking down and dilated, and there is a heterogeneous density that is involving down in a single segment or a single lobe of the lung. Can somebody tell me what is this lobe involved here? What is this lobe? Is it upper lobe or lower lobe? Is it upper lobe or lower lobe? Is it upper lobe or lower lobe in this picture? The white circle, it is the upper lobe. Okay, it is the upper lobe because I can see here, this is the place where the minor fissure should be. This is the upper lobe and this is the superior segments of the lower lobe. Didn't it fit your criteria? It should happen in the lower parts, apicoposterior segments of the upper lobes and then the superior segments of the lower lobes, right? So it fits your criteria. Ankita, you should have a problem with your internet. That is not my problem. Okay. See, now it happens, and then you see here there are small radio densities that are present in between, which we call them as cystic spaces. And such kind of a typical presentation is called as tuberculous bronchiectasis. When we learn about bronchiectasis and bronchitis diseases, I will repeat this once again. But still remember, heterogeneous radiolucencies that are involved in a segment of the upper lobe and lower lobes is called as tuberculous bronchiectasis. And this one also resembles a pattern of honeycombing. Now it means to say interstitial honeycombing is also again a pattern of tuberculosis, right? Then you see here, simple, we will just look at some places where you see here, last time I was talking about the satellite lesion. A satellite lesion is generally a tuberculoma or a tuberculous infection after a post-primary tuberculosis or a primary tuberculosis. They will appear as small and discrete shadows in the immediate vicinity of the lesion, and that is actually called as a satellite lesion. There should be a solitary pulmonary nodule, which is actually the tumor has solidified and it eventually becomes a mass, which is actually called as tuberculoma. Tuberculoma is not a cancer. Tuberculoma is a cancerous type of lesion, cancerous like lesion that is actually happening as a complication of tuberculosis infection. Okay, so which is called as tuberculoma, which is called as a satellite lesion. How can I know it? You see here, there is a heterogeneous density along with a, if you can look close here, see this patient all has got a hypodense area, well demarcated hypodense area in the left upper lobes. Okay, left upper lobe. How can I know it is a left upper lobe? Because you see here the trachea is still not divided. Trachea is presenting down as a single oval density, right? Okay, and then you can see in the middle also there is a white density, which actually suggests there is some calcification. So this is calcification. Calcifications look white, so calcification within a mass is called as a tuberculoma, which is also a satellite lesion. Okay, and it has got connections down to the other areas also. It has got a pleural tail. And now, first evaluation you should think about is always tuberculoma for a solitary pulmonary nodule. But if this solitary pulmonary nodule keeps on increasing in size, for the last 3 months, okay, before 3 months I have got a nodule like this, but after 3 months, if I take an X-ray, it became much more bigger. Now, is it still tuberculosis or is it something else disease? A solitary pulmonary nodule increasing in size over time suggests that the patient is suffering from what? See, the answer is correct. The patient might be suffering from bronchogenic carcinoma, malignancy. So, increase in the size of a solitary pulmonary nodule gives you a differential diagnosis towards the malignant lung cancers. No increase in the size of a pulmonary tuberculosis, and there is a good response to anti-tubercular medications, suggests that the patient is suffering from tuberculoma and a post-primary tuberculosis. So that's the reason we call it as satellite lesions here, and that's one we call them as pleural lesions there. Did you understand? The difference when we're talking about bronchogenic carcinoma, we are talking about pleural tail sign, right? And that's the reason we call them as pleural tail things, which is invading down into. But now here we don't call it as invasion, we call it as spread, right? There is a difference between invasion and metastasis, right? That one is metastasizing there, and now here there is an invasion, but it is actually happening because of hematogenous spread. And a tuberculoma will eventually reduce size with the anti-tubercular medications, right? And it is a cancerous like lesion that responds to anti-tubercular medications. Okay, that is what tuberculoma is. Okay, miliary tuberculosis, this is the last, very easy to understand. Miliary tuberculosis is also one of the classical presentation where the tuberculosis patient will have measure of 1 mm size small nodules that are spread all over the lung fields. Okay, 1 mm size calcified densities present all over the lung fields, which are also called as millet-like densities. Okay, rice millet opacities. Okay, rice millet opacities measuring about 1 mm in size and present all over the lung fields is called as a miliary tuberculosis. Okay, when treated, clearing is rapid, which means to say, I will find out the lesions. Look closely here. This is a normal chest X-ray. If you zoom in, you see here a small white densities are seen, and it looks completely blurred, and it seems like that there is a lot of noise in this image. And such kind of image is a very classical presentation of miliary tuberculosis. You see here, this one, this one, all these are small calcified densities and less than 1 mm in size and spread all over the lungs. It looks as if some grains of sand or grains of rice are thrown on your X-ray. So that is why we call it as rice or millet tuberculosis, or it is also called as miliary tuberculosis. Miliary tuberculosis happens because of hematogenous spread. How do you define it? We define it miliary nodules or nodules of size 1 mm spread all over the lung fields, and the clearing is rapid when treated. So it always heals with heals with calcifications. Okay, right. And you see here, when you look on a CT of this patient, you can appreciate actually why I am talking about the miliary density. Small densities spread all over the area of the lung fields you see here, and there is a focus here. See all this patient, all these densities here. That one actually shows that this is a miliary tuberculosis along with lymphadenopathy here, right? Here, lymphadenopathy, a space, okay, a focus along with completely white, small millet-like densities, miliary nodules, right? So this is called as miliary tuberculosis. Do not ever forget the radiographic appearance of a miliary tuberculosis because it can be asked as a image-based question, right? See, less than 1 mm, generally they won't be visible. If it is greater than 1 mm, yes, they are visible. And the reason for this is I am talking about, like I said before, it is always happening because of hematogenous dissemination of the tuberculous bacilli. Okay, tuberculosis, bronchogenic carcinoma are very important diseases. They can be asked you as a case, as a question. Okay, so read this topic about mixed type of interstitial lung diseases. Okay, mixed patterns of interstitial lung diseases like sarcoidosis and tuberculosis. Both of them has a high chance of being asked as a question. You need to write all the slides of what we are talking about. Okay, you will have something around like 4 images to diagnose. You will be asking about the risk factors, you will be asking about the treatment, you will be asking about the diagnosis, clinical diagnosis, and also radiographic diagnosis. You will be asked about the complications. Everything is very important here. Okay, So now, is it clear? Is this topic clear for everyone? Right? Is it clear? Please read this 2 times, 3 times. If you do not understand, I will repeat once again. Okay? But try to understand the radiographic features, because the diagnosis of tuberculosis is highly investigative, made on radiology. Radiology has got a 99% sensitivity and specificity for diagnosis of tuberculosis. So you cannot ignore this disease. Okay? Right. Who was asking about the Simon focus before? Somebody was asking me about Simon focus. Right. I think Martin, you had some kind of a question too. Martin, are you there? Respond, guys. Waiting for you. Reshma, are you here? Martin, are you here? But the person who asked about that question, she's not here. Yeah, I know, Martin. What was your question? I guess you are the one who is asking about this extrapulmonary tuberculosis, right? So what did you ask? I find that you also had a question related to something. Right. Okay. I think Reshma is still not here, I guess. I don't know if she's here, not here. Let me check. Yeah, Reshma is here. Then why doesn't she respond? Yeah, aren't you the same person who asked me about Simon focus? Yes or no? Okay, just came, huh? Yeah, okay. Simon focus is a calcified focus that is generally seen in the upper lobes of the lungs, which happens because of extrapulmonary tuberculosis as the primary cause, which means to say there is a primary tuberculosis that is present down in other parts of the body, and from there the tuberculosis has spread down to the lungs, and it eventually became calcified. So that is a Simon focus. But Gons focus starts down in the lungs. Gons focus starts in the lungs and spread down to other parts of the body, right? Other parts of the body, or generally say other parts of the lungs. Focus that spread down to the other parts of the lungs is called as Gons focus. But extrapulmonary tuberculosis comes down into the lungs and finally eventually forms a calcified focus that is called as a Simon focus. Okay, right? Okay. And let us try to understand one other simple concept. It is there in your practical slides, but remember it here that way itself. A calcified Gons focus along with a calcified lymphadenopathy is called as a Ranky complex. Okay. a Ranky's complex. Ranky's complex is a calcified focus along with a calcified lymphadenopathy is called as a Ranky's complex. It is also called as the primary complex of the tuberculosis. And tuberculosis has also got another one typical presentation, which is also called as tree in bud appearance. Okay, tree in bud appearance. Okay, it has got a tree in bud appearance. It is there in your practical slides. Once go back and also read about the pathology in the practical slides as well. Okay, it is there inside all the practical slides. Okay. Yes, my camera is off, but you can't listen to my voice in this, right? No, you why? You miss me? Do you want to see me or what? Right. Okay. So now let's get into one more smaller chapter. This is very easy chapter. It is not difficult at all to understand. It is quite easy because we got the best basic right now. Okay. Right. Now, see, we have to understand all the things that we have been dealing about before is everything that is related down to opacities on a chest x-ray, right? Opacities down in the thorax radiographs, consolidations, and then we are talking about ground glass opacities, we are talking about fibrosis, we are talking about uh, a lot of the something like solitary pulmonary nodule. We have seen bronchogenic carcinoma and everything. All of them are something that they are masses. But now we are trying to look at some kind of individual diseases that will actually cause, a complete opacification of a single side of a lung. Okay, chest, let us say. If there is an opacification, it is a broad opacification that is present down unilaterally and extending down in most of parts of the lungs. We call it as an opacified hemithorax. Okay. And it is always necessary to understand the causes of the opacified hemithorax because the confirmation diagnosis is made on radiology itself. It is entirely different from the airspace disease and interstitial lung disease. So, which means to say there are specific causes and they have specific radiographic features, and you cannot confuse this opacified hemithorax along with the causes of airspace lung diseases to interstitial lung diseases. So, the differentiation features is made upon the radiology itself. So, somebody has to always recognize the causes of opacified hemithorax. Now, actually, what are the causes of opacified hemithorax? The first thing we are going to deal about is the atelectasis of the entire lung. Atelectasis is a little bit different from your, lung collapse, but I will deal about that one. But still, you call it as atelectasis of entire lung. First main important reason, and then we have massive pleural effusions, and then pneumonia of an entire lung, and then pneumonectomy patients. Pneumonectomy patient is something that removing a lobe or a segment of a patient in a lung. We call it as pneumonectomy. So these are the main four important diseases that actually related down to cause an opacified appearance of a hemithorax, right? Okay, let's start with atelectasis or whatever. Let's try to understand. You see here, Mr. Smith, who is age 31, comes down to the emergency department with an acutely shortness of breath. And you see here, Mr. Smith's left hemithorax is completely opaque. Yes, you see here, there is a big density that is present. See all the left lung, you cannot demarcate the shadow of the heart. You cannot see out any kind of black shadow that is present over the lung. left lung, you see here, and it is completely white and white in nature, right? Now, what do you think this guy might be suffering from? I told you that there are four reasons: atelectasis of the entire lung, massive pleural effusion, pneumonia of an entire lung, or pneumonectomy. Now, you look at this image carefully, just pick a choice, because we don't know about the details yet, but just try to say, okay, what exactly this person is suffering from. What could be this patient's condition? Atelectasis, right? Okay. Now, I guess maybe you guys have been reading the slides, so that's a good answer. It is atelectasis. But how did I know that this is atelectasis? So there are some ways to find. First topic is atelectasis, so that's the reason you are saying atelectasis, huh? Okay, don't worry about that. Right. How can a radiologist actually know that this person has atelectasis or pleural effusion, or if it is a pneumonia of entire lung, or if it is pneumonectomy? There are certain hints for a radiologist to find out on a radiograph and differentiate between these four opacities. Okay, so how will do it? It will actually depend. Okay, let us say, because unless I make the diagnosis, I cannot treat the patient. Now, like what I was saying, if atelectasis is the complete collapse of the lung, okay, if atelectasis is collapse of the lung, then maybe the patient will be requiring to decompress the lung. Decompress in the sense, okay, wherever the compression has been made, now it want to be taken down into the normal inflation. So now you have to remove that, whatever that is problem that is present there and causing the complete collapse of the lung. That is the treatment. Or let us say if there is a large pleural effusion, yes, maybe the patient will be requiring a procedure called as thoracentesis. Thoracentesis means to say extraction of the pleural fluid from the lungs, pleural cavity. Not exactly lungs, but you call it as extraction of the pleural fluid from the thoracic cavity. Now, I say I made a misdiagnosis of the collapse of the lung, and then I started piercing down the chest with a bore needle, and then I'm thinking, okay, this patient might be suffering from a pleural effusion, and I'm doing thoracentesis. But actually, the patient is suffering from atelectasis. Now, do you think that my treatment is justified? Obviously, no. I am causing it where there is no atelectasis. I am causing now atelectasis. Where there was no pneumothorax, now I am getting the air from external environment into the thoracic cavity, causing him a pneumothorax, right? So, do not misdiagnose the situation. So, it is always very important for a radiologist to find out what exactly is the reason behind that opacity. Now, let us try to understand how we were able to do that one, right? There are three major causes: atelectasis, pleural effusions, and pneumonia, and a small cause called as pneumonectomy, which is iatrogenic. Iatrogenic in the sense it is done by the doctors. Okay, it is a surgical procedure. So this one actually also will cause an opacified hemithorax. Atelectasis, pleural effusions, and pneumonias are diseases. Pneumonectomy is caused by a treatment. Okay. So first we will talk about atelectasis. Atelectasis of an entire lung actually results from a complete obstruction of the airway. Okay, atelectasis, the collapse of the lung, or a collapse of a segment, or a collapse of a lobe, happens because that there is an obstruction to the bronchus that is supplying air to it. As simple as that. So the most important what happens is when there is a bronchial obstruction, the air cannot enter from outside to inside, okay, through the trachea or through the bronchus, and the remaining air in the lung is absorbed into the bloodstream through a pulmonary capillary system. So since oxygenation has been going on, now what happens is that, okay, air cannot enter from the trachea to the bronchus and to the part of the lung. The other parts of the lungs, actually the remaining air will be absorbed down into the bloodstream, and completely it gets collapsed. It's same like how your balloon is getting deflated. Your balloon is also coming down closer and closer and closer as the air goes and goes off away, right? That's the same way how it also happens down into your lungs too. And this one eventually leads down to the volume loss of the affected lung. Now, all the shrinked lung comes down to a single place, increases the density, and increasing that density will eventually cause opacity. Simple. First thing, why there is an opacity if there is a collapse of the lung? There is opacity of the lung because all the lung has been shrinked down and come down into a smaller place, and which has increased density. And increased density looks like white on an X-ray. Simple. And it is due to loss of volume, right? And as the air is being absorbed down into the bloodstream through pulmonary capillary system, right? And one of the most important causes is asthma, okay? Asthma, which actually happens because of the mucus plux. So mucal obstruction, not mucoid. Mucoid obstruction means to say it is talking about the fungal problems. Okay, this is mucus obstruction, mucosal obstruction, right? In asthmatic patients, where there is an inflammatory condition, where there's a histaminic reactions are happening and there is an excessive production of the mucus, and eventually the mucus gets clogged down into the smaller bronchioles, or sometimes get done obstructed down into the bigger bronchioles, will eventually cause that bronchus to be completely obstructed. And in younger individuals, this is much more common. Asthma is the most common cause of atelectasis of the lungs, which actually happens because of mucus obstruction. And in an older individual, in an old age patient, generally it might be happening because of a condition called as bronchogenic carcinoma, obstructing neoplasm. And obstructing neoplasm, a neoplasm inside the lung will eventually counter compress the bronchus, and there is no air that can be entered further. So bronchogenic carcinoma happens in older individuals. Asthma mucoid impaction uh, will happen in children. When it been coming down to infants, okay, the most common cause is actually happening because of a foreign body. Okay, it is actually happening because of a foreign body. Now we were talking about in the general principles. Okay, the foreign body can be obstructed down. If there is a foreign body is obstructed, we indicate a chest x-ray to find out the location of the foreign body. That's the same strategy should be applied here to also find out which part of the lung is obstructed, which further bronchus or the further branch of the tree has been obstructed. You have to try to know about the exact location so that you can actually decide the treatment of the patient. Okay, now let's try to look at some radiographs. The first thing, if it is actually happening because of obstruction, we call it as obstructive atelectasis. Okay, right? So even though there is a volume loss within the affected lung, the visceral and pleura almost never separate. Now you have to understand a very important observation here. You see here, the visceral and the parietal pleural layers are not separate, which means to say there is something around like 5 mm of gap between the visceral layer and the parietal pleural layer. Now they are closely attached together, right? Where the visceral layer is completely present over the surface of the lung and parietal pleura on the lateral side, and there is a gap of 5 mm in between them. There is nothing in between them, right? Except for a very little amount of 5 to 10 ml of pleural fluid. But it is not pleural effusion, right? So in obstructive atelectasis, there is no air in the pleural cavity. If there is air that is present in the pleural cavity, we call it as pneumothorax. But in obstructive atelectasis, there is no air between the visceral and parietal layers. First important thing that you have to observe here. So this kind of knowledge actually helps you to differentiate if the problem is happening, if the opacification is happening because of pneumothorax, or if it is happening because of atelectasis. First point to care here, right? So In obstructive atelectasis, the visceral and the pleural layers are never separate, and they do not separate. Now, what actually happens is that they will pull all the lung towards the side of atelectasis, which means to say there is ipsilateral pulling. Okay, there is ipsilateral pulling and producing a shift movement of these structures towards the side of opacification, right? Wherever the bronchus is obstructed, and the complete lung will be pulled down to that side itself. So ipsilateral obstruction, single side obstruction causes ipsilateral opacification. That is the first thing you have to remember. And then most visible structures in the thorax are heart, trachea, and the hemidiaphragm. Now, what actually happens is that the contour of these structures is completely lost. That is the second radiographic feature. First, there is an ipsilateral shift, then the contour of the visible structures in the thorax is lost. So all of these structures, then what actually happens also that one or all of these structures will also shift towards the side of opacification, toward the side of volume loss. Okay, we will talk about that mechanism when we look at the radiograph, but first try to remember them. What happens is that these structures, the heart, the trachea, and the diaphragm, will be pulled towards the same side. So ipsilateral mediastinal shift, ipsilateral tracheal shift will happen due to obstruction on some side. Now let me give it more clear way. If there is a obstruction in the left upper lobar, or let us say left lower lobar bronchus, then the trachea will be shifted down to the left side. That is what ipsilateral means. The mediastinum will also be shifted down to the left side. The hemidiaphragm will also be elevated down onto the left side. So that is will cause an entire opacification of that side itself. Did you understand this? Is this concept clear now? Yes. The first thing what happens, the bronchus has to get obstructed. The next thing what happens, the lung will eventually get collapsed because of the capillary pulmonary system. Then what happens, it will be pulled down towards the same side. The lung is pulled down to the same side, which eventually pulls the trachea onto also to the same side, pulls the mediastinal structures also to the same side, and causes the complete respiratory volume loss there, and eventually the respiratory is completely absent in that side. So that's the reason the hemidiaphragm is also elevated on that side. So absent lung sounds are seen in atelectasis. See, in your diagnostic class, you will learn, okay, absent lung sounds or dull resonating percussion sign is actually seen down in atelectasis and pleural effusion. That is how we see it. Okay. In pneumothorax, we will be seeing hyper-resonant, but in atelectasis and pleural effusion, you will be seeing woody-like dullness over the chest. Okay. If your diagnostic teacher has taught you this one, maybe you can associate it there. Absent lung sounds will be present. But and the same thing is also evident down on your radiograph as well, right? Now let us see it. Look at this chest x-ray. This obviously shows that this is a child, okay, because the ribs are not well developed, and you see here the clavicles are smaller in contour, right? And this is a child. Now, what actually happens is that I see here the entire left lung or the entire hemithorax, left hemithorax is completely white in nature. And the black arrow actually, now you see here, it actually has to be on the other side of the spine. But now what actually you see here, I can see almost the lateral borders of the spine on the right side, which means to say the heart has been pulled on to the left side. Opacification is present on to the left side. And you see here, the heart is also pulled down to the left side. And then you see here, even the trachea also is pulled down to the left side. Yes. So now this both the radiographic features, tracheal deviation to the left side, along with the mediastinal shift to the left side, both of them suggest me that this patient might be suffering from a obstructive atelectasis. Now, can you take a wild guess and tell me, and which lobe of the lung has been collapsed here? Is it upper lobe, lower lobe, whatever? Which one is obstructed here? If you have been following up all the anatomical classes that we were talking about, tell me which you will be able to answer this question. Which lobe of the lung do you think has been obstructed here? Upper lobe. Upper lobe. It is the lower lobe. Okay, it is the lower lobe, and there is a complete obstruction to the bronchus intermedius. Okay, bronchus intermedius. Okay, or let us say lower lobar bronchus. See, now this is where most of the people actually get confused. Why? Yeah, see, that the answer to this question does not come down from zooming it, but actually the answer to this question comes down by understanding the process of atelectasis. Uh, okay, right? Just wait. I will open up my camera first for a while because somebody was missing me hardly. Uh, let me see once. Okay, I think. Okay, I don't know. Can everybody see me now? Yes, no, no. Okay, just wait, just wait. Yes, can you see me, guys, or no? Uh, let me see. Wait, wait, hold a second. Okay. Just wait. I had a little bit of a problem because I can't see myself. Because Mrinimai, can you actually close your camera? I guess Mrinimai's camera has been obstructing my view, right? Okay. Now you see here. Let us try to understand what actually happens to these patients. Uh, let me find one thing. Okay, just give me a minute. Okay, it's a very easy logic to understand. Now let me say this is a lung. Can everybody see me? Can everybody see me? Yes, right. Okay, this, let us imagine that this pen is a trachea. It's present down in the center. Now let us imagine this part is the upper lobe of the lung and this part is the lower lobe of the lung. Got it? Is it clear? This is the trachea. The pen is the trachea. Okay, the pen is the trachea. This is the upper part of the lung, upper lobe of the lung, and this is the lower lobe of the lung. Now, let us say that this is actually, there is a lot of air in it. Okay, there is a lot of air. Now, what actually happens is that slowly and slowly, now the trachea will actually, this one is collapsed and collapsed and collapsed and collapsed. Now, this one is actually pulling my trachea. And you know that as a matter of fact, that the left upper lobe has got two bronchuses in them, apico-posterior bronchus and anterior bronchus, right? Now those two things will eventually get collapsed if there is an obstruction, and there will be tracheal deviation in the upper part of the trachea, right? Just above the carinal angle, just along the carinal angle. But if it is in lower lobes of the lungs, you see here, all the bronchus intermediates and the main part of the lung is collapsed. Now, what actually happens is the trachea is being pulled because of the force. All the thing is coming down together, and it is pulling down because there is a heavy force onto the bronchus there. That's the reason there will be a tracheal deviation. In the upper lobes of the atelectasis, actually, you cannot see a very, very typical tracheal deviation. But if it is happening in the lower lobes, yes, you can see the tracheal deviation very, very clearly. Did you understand this concept? Okay. Did you understand it? Or do you want me to repeat it? See, upper lobe will eventually pull down only small, but you see here, the upper lobe of the left lung has got only two segmental bronchuses in them. But all other, let us say, is that the lower part of the next bronchus branch is actually going down to be obstructed. Lingular segments are getting collapsed, lower segments are getting collapsed, and all this one has got a high force onto the trachea, which eventually will pull down the trachea like this, which has to be present straight like this, now get pulled out like this, right? So that is why I can say it is actually happening because in the lower lobe, atelectasis. Did you understand? It is not upper lobe. And if it is, it will be much more easier to understand if it is present down in the right lung, but here it is not really so sensitive enough. Okay, how is that possible, Benedict? I guess you did not follow it. How many people did not follow what I have been just talking about here? Okay, let me explain once again. You see here, imagine this is the lung, imagine this is the trachea. Okay, there is air present in it here, and the trachea is like this. Now let us say if this part of the lung is being collapsed, okay, in the upper lobes. Well, because I do not have a diaphragm below, lungs are not floating. Who said lungs are floating? Lungs are inflated and deflated. Lungs are not floating like the heart, or not like the brain. Lungs are inflating and deflating within the thoracic cavity. They are not floating in the thoracic cavity. Is that clear, Benedict? Okay. See, now what actually happens is that there are only two segmental bronchuses in the upper lobe, apico-posterior segmental bronchus and anterior segmental bronchus. Now, they are a smaller area. They are attached to the bronchus, but if there was have been an obstructed down to the upper lobe of the lung, only this part will get it. And this part eventually, if the bronchus intermedius, which is the biggest bronchus that is present, will still has air in it, right? So which means to say this one still be radiolucent itself, yes or no? Bronchus intermedius is the biggest one that is present, that is supplying down to the lower lobes. But let us say if the upper lobar bronchus has been obstructed, only upper part of the lung will be, collapsed, right? But now let us say if the main bronchus has been obstructed, right, left main bronchus has been obstructed, all the bronchus that is supplying down to the upper lobe and lower lobe are completely obstructed, then what actually happens is that, see, it is pulling up. It is not, see here, the bronchus is not pulling medially, the bronchus is being pulled laterally. Benedict, you are wrong. If the bronchus is pulled medially, it will become contralateral. Here, the bronchus is being pulled down to the same side, which means to say the bronchus is being pulled down to the lateral side. It is actually happening because of the compression of the lungs, and all the bronchuses are accumulating at the same place. See, all these bronchus, since the lung is collapsed, all the bronchuses are accumulating down to the same side, increases the density, increases the mass of the lung, and that is the one that is pulling down. Get it? The bronchus is not pulled medially, the bronchus is pulled laterally. Is that clear? Please respond, guys. Is this clear? Right? Yes, your thinking is correct, but yes, you are just wrong with the direction. That's it. Okay. All the bronchuses are collapsed. All the bronchus came together. That's the reason I see an opacity. One thing, the heart also came down to the same side. But why is there is an ipsilateral tracheal pulling is just because the air is not coming and all the bronchuses are pulling onto the same side. So that's the reason what happens. The trachea is moving away from the central line. Moving away from the central line, we call it as, yeah, the same thing. Upper lobe will have a little opacity here. Upper lobe is not the one that is taking up the larger space, right? Larger volume is not present down in the upper lobe, right? So upper lobe will be having radiolucent, but upper lobe cannot completely compensate of that lungs thing. So what happens eventually? The upper lobes also will get eventually collapsed. Did you get it? Did you understand it, Nitish? Okay. Upper lobe cannot compensate the whole thing because the soul, yeah, one is the GV force, yes, gravitational pull, and also other things that the pull of the bronchuses towards them, right? There are two things that are happening here. So that is the pathophysiological mechanism of atelectasis. Now let's look into the pictures again and try to analyze it once again if we have made it correct or not. Okay, you see here. Now you see here, compared to the opacity that is present down on the lower side, upper side, eventually the upper lung also got obstructed. By this, actually, I came to understand that the left main bronchus has been obstructed. Okay, that is, see here, the patient was actually, it shows up that the whole opacity has been present down, which means to say the obstruction is present down in the left main bronchus. But if it could have been present down in the segmental bronchuses, yes, the mechanism what I've been telling is much more evident. And now you see here, since the main bronchus has been obstructed, what happens is that, okay, all the bronchuses came together, all the things that have been increased, and one, yes, it is increased density causes the opacity, and increased weight in the same lung region will cause the tracheal pulling, because all the bronchuses are connected down, okay, as a tree. If you pull one branch, all the branches are pulling along with them. So that is the reason it is pulled down laterally. Got it? So which is actually called as ipsilateral pulling, right? So that is the main characteristic features of atelectasis, right? Okay. Is this concept clear for everybody now? Yes, perfect. Now let's move on to the next part of this chapter, pleural effusions. Now understand, pleural effusion is nothing but also that causes the opacification of the hemithorax. But understand, like what I was telling in the previous classes, pleural effusion is filling up of the pleural cavity by mucus, sorry, by blood or fluid. A fluid filling inside the pleural cavity, or a fluid accumulation between the visceral and parietal layers, is called as a pleural effusion. Now, what actually happens is that there is an increased pressure inside the pleural cavity. Here, the problem is not present inside the lung. Did you guys understand this? The problem is not present inside the lung. The problem is present because of the fluid is being accumulated in the pleural cavity. So, increase in the fluid in the pleural cavity will counteractively push the lung onto the opposite side. So eventual collapse is happening in that part of the lung. right? And same time, the pressure keeps on building and building inside the thoracic cavity. So eventually what happens, the trachea will be slowly and slowly deviated to the other side because of the pressure increasing in the pressure, right? As if I am pushing a car, right? If I'm standing on the back of the car and I push it, the car will move forward. The same way that is actually happening here. The fluid accumulation, as the fluid increases and increases inside the pleural cavity, the lung will eventually get collapsed. At the same time, the fluid, more accumulation fluid, will eventually push the trachea onto the contralateral side. So any kind of a filling inside the pleural cavity will cause contralateral tracheal deviation, and also will cause, okay, and also will cause the mediastinal structures to the other side. So contralateral mediastinal shift along with contralateral tracheal deviation happens in pneumothorax and pleural effusion. Is this concept clear now? And fluid density is white, and it also act like a mass that is compressing the lung, right? So there is an atelectasis also, counteractive atelectasis, because of fluid filling inside the pleural cavity, will cause pushing of the trachea away from the central line. So there is a contralateral. Okay, got it? Is this concept clear? Please respond, guys. Right? Ipsilateral tracheal deviation happens in atelectasis. Contralateral tracheal deviation happens in pleural effusions and pneumothorax. Okay, but pneumothorax is not a radio opacity, so that's the reason we are not dealing it here. Now look at here. See, this is a very, very typical picture. You can appreciate all the things very so much very good here. You see, in this radiograph, I can see a white opacity that has been obscuring the shadows all over the lungs. I cannot see the costophrenic recesses on the right side. The rib shadows are not clear. Okay. The rib shadows are completely blurred out, completely obscured. And when I look closely, you see here, when I look closely, there is the trachea, the central line, which actually appears as a black line in the along the central line, now came down to the lateral side towards the left side of the vertebral bodies. Because the opacity is present down on the right side, the trachea moved down to the left side. So this is contralateral tracheal deviation, because the all fluid filling here will eventually act like a mass and push the trachea away. And now also you look here, the pressure increased in the inferior mediastinum, also pushed the heart towards the left side. There is an apical shift. This is the cardiac apex, so there is an apical shift, cardiac apical shift. Now this one is, it shows that there is a massive pleural effusion, and there will be fluid filling, and that will actually happens because of primary bronchogenic carcinoma. Lung cancer is the most important cause to cause a massive pleural effusion. Two days ago, somebody was actually showing up me an X-ray and asking me to analyze the pleural effusion. Did that guy understand now what exactly I'm talking about? See, that's a good question, Rejwan. Pleural effusion is prominent in upper lobe or lower lobe. Fluid, remember, don't ever forget this logic. Fluid is always present down in the lower parts of the lungs, because it is a fluid, and it actually, there is a gravitational force working on it, and when the gravitational force actually happens, fluid settle down in the lower parts of the lungs. You cannot technically say unless there is a fluid increasing slowly and slowly and slowly, same like the way how the level of the water increases while you fill up your bottle. That's the same way happens, either it happens in the lower lobe or upper lobes. Okay, if there is so much filling from bottom to the top, as the fluid starts filling slowly and slowly, you have do not have to You should never ignore the effect of gravitational force here. Okay, right? Did you understand? Rajwan, did you understand? Fluid filling always happens in the dependent parts of the lungs, dependent parts of the thorax. Okay, right? Now, the other thing, so that is what it is, tracheal, the contralateral tracheal deviation along with the contralateral tracheal shift and the apical shift. Okay, along with the opacity that is present here. Right. Massive pleural effusions are happening because of bronchogenic carcinoma or secondary to the metastasis of the pleura. Metastasis of the pleura, we were talking about Lamb's disease last time, right? Lymphangioma, myomatosis, right? In such kind of disease, there will be a condition called as chylothorax. Remember? Chylothorax. Chylothorax is nothing but, there will be, there will be filling up of bile inside the pleural cavity. Okay, filling up of the bile inside the pleural cavity is called as chylothorax. If there is blood, it is called as hemothorax. Okay, and if there is fluid, we call it as effusion, pleural effusion. Bronchogenic carcinoma, lymphangioma, myomatosis, tuberculosis. Okay, technically speaking, primary tuberculosis are the most important reasons for causing massive pleural effusions. Okay, now trauma, penetrating trauma will eventually rupture the blood vessels. Okay, inferior, costal arteries. Okay, inferior costal blood vessels, they will rupture them and eventually causes, and subcutaneous blood vessels are ruptured, so they can cause hemothorax. And tuberculosis is one of the most important notorious reason for causing large clinically silent effusions. Okay, massive pleural effusions, most common cause is tuberculosis. Next common cause, if it is happening, is because of bronchogenic carcinoma, unless and proven otherwise. Okay, if there is no risk factor of bronchogenic carcinoma, confirmatory diagnosis is not made on pathology, maybe the patient should be treated with tuberculosis first. So tuberculosis is the most more common cause, and next bronchogenic carcinoma. Okay, bronchogenic carcinoma should be observed, and for both of them, CT is the best diagnosis. Okay, right. Congestive heart failure also is very common. Okay, and which will actually starts giving out the translator fluids, filling up down, but actually the congestive heart failure generally do not try to produce large pleural effusions. Moderate grade pleural effusions or minute pleural effusions will be happening, will be able to see in congestive heart failure patients. Okay, it actually depends on the cardiac output. It actually depends on the how much part of the heart or which side of the heart has been failed. So it actually depends on the BP of the patient. Okay, if there is more BP, third grade hypertension, complete heart failure will eventually cause a large transitive fluid effusion. But little BP, less cardiac output and other things, yes, it will eventually get. So speaking here, a cardiopulmonary compromise is present. So if a patient is suffering from bronchogenic carcinoma, X-ray is going to be a confirmatory diagnosis to diagnose it along with CT. But if it is happening because of congestive heart failure, what are we going to look at? We are going to look at not X-ray, but we are going to look at echocardiography, because echocardiography will calculate your ejection fraction and cardiac output along with valvular function. So that's the reason echocardiography in case of congestive heart failure makes the confirmatory diagnosis of pleural effusions. Okay, right? Is this clear? Did you understand what is the diagnosis difference between congestive heart failure, pulmonary tuberculosis, and bronchogenic carcinoma in case of pleural effusions? Did you understand it? Right? Okay, nice. And then there may be a perfect balance between the push of the malignant effusion and the pull of the obstructive atelectasis from the malignancy itself. So now we can clearly differentiate. Sometimes atelectasis can also be accompanied along with effusions, which might be happening in a disease like tuberculosis. Tuberculosis caused progressive tuberculosis has caused progressive pulmonary fibrosis and collapse of the interstitium, which caused complete atelectasis. So atelectasis is seen in the same side, and pleural effusion can also be seen on the same side. Malignancy, the bronchus is completely obstructing, the bronchogenic carcinoma is completely obstructing the bronchus, mass is pulling down the trachea, and there is a large pleural fluid filling. So mixed up features also can be seen, but still you have to remember it in a plain way that the contralateral uh, mediastinal shift and contralateral tracheal deviation happens because of the problem that is present down in the pleural cavity, acting down as a counteractive mass pushing them. But ipsilateral tracheal pulling and ipsilateral mediastinal shift is happening in atelectasis. Okay, both. It actually comes down to through a little practice, but that is the basic scenario behind it. In adult patient with an opacified hemithorax, there are no air bronchograms. So no air bronchogram means to say no pneumonia. How can I differentiate pneumonia from pleural effusion and uh, you know uh, atelectasis? No air bronchogram, and there will be no volume loss in pneumonia either. But there is volume loss here, so that is how I differentiate, right? So CT scan of the chest also will really reveal some abnormalities. Now let's try to understand a CT scan here. You see here, there is a hypodensity or a fluid filled density in the complete right lung. Can somebody tell me, is it happening in the upper parts of the lungs or the lower parts of the lungs? Can somebody tell me, is it in the upper lobe or the lower lobe? Lower. Why? I cannot see trachea no more. Trachea, I cannot see it, trachea anywhere, right? And then, like I always saying that the fluid will be get filled down into the lower parts. Okay, the person is in supine position, the fluid filling, but you cannot differentiate the fluid filling here because the complete lung has been filled up, and fluid density will look hypodense here in the mediastinal window. Okay, this is the mediastinal window. Don't ask if it is an opacified hemithorax. Why is it looking black? It is not looking black, it is looking gray, which means to say on CT, if you are looking in lung window, it will be completely white. The window mode I am looking at here is the mediastinal mode because the heart structures are also looking gray. Okay, this is not lung window, this is a mediastinal window. And you can see here, if you look closely, this density is a little bit lower than this density. This is higher density, which means to say this is the collapsed lung. And you can see here small black dots here. These small black dots actually indicates that these bronchuses, now these bronchuses completely came together. And you see here, these white dots are the pulmonary vessels, right? These are the pulmonary vessels, and this lung is completely shrinked. So there is a counteractive atelectasis of the one, right? And there is no tracheal deviation. There won't be tracheal deviation. There could have been a tracheal deviation, but I'm not looking at that level. And now you see here, the heart also moved down to the other side, where actually this is the area of the pulmonary. I cannot completely see the right pulmonary artery, but here it came down into the central line, which has to be present down here, but now it came down to the central line. And you see here all the place. Now this one is actually happening because of a bronchogenic pulmonary carcinoma. So here is it, the mass, right? Did you understand the radiographic features here? Don't tell, based on this image, don't write that the pleural effusion looks black. No, it looks white, obviously. The only reason is that I am looking at it in a mediastinal window. That's it, okay? Real black has to look like this, but fluid will look gray. That's what we learned, right? That's it. So pneumonia, we are going to complete it off very fast. I will do it in within 10 minutes itself. Now pneumonia, like other I was saying, it will not be pulled towards this side or be pushed away. There will be no contralateral tracheal deviation. There will be no ipsilateral tracheal deviation. There is no ipsilateral tracheal deviation and mediastinal shift. There will be no contralateral tracheal deviation and mediastinal shift. By that, first I can understand. First, every time, anytime I'm looking at a chest radiograph, I am trying to look at the trachea if it is present down in the center or not. That's the first step any radiologist will do. Look if the trachea is present down in the center. If it is present down in the center, yes, now go on. Think about pneumonia. If it is not present down in the center, and if there is contralateral deviation, I'm thinking about pleural effusion. If it is if it is ipsilateral deviation, I'm thinking about atelectasis. But in pneumonias, yes, it is a consolidation. Consolidation is an opacity. Opacity will look like a bigger white structure that is all over the lungs, right? And there is neither pulling or pushing of the mediastinal structures of the trachea in pneumonia. And pneumonia is characterized by air bronchogram pattern. So I will be seeing air bronchogram, right? Look at this image. It is a nearly almost complete opacification. You see here, the heart is present in the same way. How can I know? Because this is the right atrial shadow, which is present down on the right lateral border of the vertebral bodies. So which I can understand that the heart is no deviation. There is no shift of the mediastinal structure. And you can see here, trachea is always in the center. I can clearly demarcate the carinal angle as well. So which means to say there is no splaying of the carinal angle, there is no pruning of this carinal angle, there is no shift because I can see the tracheal radiolucency over the spinous processes. So which means to say trachea is center. But still I can see a opacity present down in the left lung. Now this clearly suggests me that it is happening because of pneumonia. It is not happening because of atelectasis. It is not happening because of pleural effusion either. Because in atelectasis and pleural effusion, there will be counteractive lung compressions. Yes or no? Is this concept clear now? Once again, right? And also you see here, when compared to the lower parts of the lungs, I can see there is an increased opacification on the upper lobes. This one is a little bit grayish in color, but this one is much more whiter in color, which actually says that there is an air bronchogram pattern. I can see also trachea that is present here. See, so this is actually air bronchogram pattern is nothing but a radiolucent bronchus that is present between a consolidative opacity is called as an air bronchogram pattern. That is what we learned in the definition, right? So I can see the trachea that is present as a radiolucent density present within the hyperdensity or a radio-opaque shadow, which is consolidation. So this I call it as an air bronchogram pattern. Simple. When I zoom in closer also, I can also see other segmental bronchuses also going from here. You see here, see these black lines. Okay, this is the epico-posterior segmental bronchus, and this is the anterior segmental bronchus I can see here. And this is the main bronchus. See, and this is the bronchus intermediates. All the bronchus are visible. It means to say bronchus is not obstructed. If the bronchus is not obstructed, I am not thinking about atelectasis. If the bronchus is seen, I am not thinking about atelectasis. If the bronchus is also not seen, rib shadows are also not seen, there is a contralateral tracheal deviation, I'm thinking about pleural effusion. But such features are not present in this image, so that's the reason I'm thinking about only pneumonia. Did you get it? So most common cause of pneumonia is streptococcal pneumonia, where the sputum will be there, and right, rather than suggesting atelectasis and pleural effusion, my radiographic will pull me the diagnosis towards a pneumonia, right? Is this concept clear? Yes or no, guys? Did you understand the densities? Clear, right? Okay, let's move on to the last topic for today. It is very easy. Pneumonectomy, like I was telling before, it is caused by a doctor, right? It is caused by a doctor. Pneumonectomy is nothing but removing some parts of the lung, either lobectomy or segmentectomy. Generally, you are calling it as removing an entire lung is also called as pneumonectomy. You don't call it as lungectomy, okay? You call it as pneumonectomy. There is no term called as lungectomy. Removing a segment, pneumonectomy. Removing a lobe, lobectomy, okay? But removing the entire lung, generally you call it as pneumonectomy. It is not called as lungectomy, okay? Right. Okay. So what actually happens is that generally when we are trying to perform a pneumonectomy, what we actually do is that the surgical procedures such as that an incision has to be made along the level of the fifth and sixth thoracic, fifth and sixth ribs, and then either sixth and fifth rib has to be removed. It has to be completely removed because there is a less space that is present between the ribs. You cannot pull out all the lungs, all the lung from that small gap. So what actually we do is that we remove a rib. So first important radiographical feature is that you will be having less ribs. Did you understand the point now? In pneumonectomy, you are removing a rib. So what happens that there is a loss of rib number, decrease in the rib number, and especially at what level you are looking at the fifth and sixth ribs usually because of the surgical procedure protocol. And now whenever there is all the bronchuses are there, and there are all pulmonary vessels, if I'm just cutting the lung and removing it, the blood will be flowing out. So what I have to do is that I have to ligate the pulmonary vessels. I have to ligate all the connections, all the capillary connections. So what I do, how do I ligate them? I ligate them with a metallic surgical clip. I am also finding out the sutures, right? I am trying to use the sutures. I'm also using a clip to completely close up the pulmonary vessels, which will actually leak out. So what I do, I will find a metallic surgical clip and a rib that has been removed. Most important radiographic features which will suggest me this is not pleural effusion, this is not pneumonia, this is not atelectasis. Did you get it? It is very simple. Pneumonectomy is very simple, right? Then after 24 hours following the surgery, only air occupies in the hemithorax, because when I expose the thorax down to the external environment, all the air enters. But later, after 2 weeks, what happens is that gradually it fills up with fluid. Okay, right? And after 4 months after surgery, the complete pneumonectomized hemithorax should be completely opaque. On the first 24 hours, because I opened the thoracic cavity, air is filled. But once I closed the patient along with surgical clips, what happens is that because of the congestion and fluid exchange, okay, diffusion is happening. So what happens is that slowly and slowly it fills up with the fluid, and then after 4 months it will become completely opaque. But still the radiographic features do not change. The radiographic features what I have is that, okay, one rib shadow is not visible, right? One rib shadow is not visible and metallic surgical clips are present, right? That's it. Now you see here, look closely. This is a 24-hour patient, where this one you see here, when you compare to the blackness of this lung to the blackness of this lung, you see here this is much more darker. It is much more blacker. Now let me try to count the ribs. Let me try to count down the ribs. Okay, rib number 2. Okay, rib number 1, 2, 3, 4. See, I cannot see the fifth rib. Sorry, 5, 6. But you see here there is an increased gap here, so I cannot see the fifth rib. So I am removed of this rib. Okay, and then you see here there are metallic white densities. Metallic white densities, metals look white, so I removed of them. So these are surgical clips. They are placed in order, right? So this is the first 24 hours patient. Now generally, even after the fibrous tissue will also be formed because it should be healing, right? And entire hemithorax is completely opaque. Then the heart and trachea also shift towards the side of opacification, right? They also shift to the side of opacification. So there is ipsilateral tracheal shift and ipsilateral mediastinal shift. Okay, just examination almost look identical to the patient with atelectasis, but how are we going to differentiate? We are going to differentiate between the missing sixth or fifth rib and then surgical clips. That is how you are going to differentiate it, right? See here, look closely. This is a very interesting image. You can almost see that there is a deviation of the trachea. You see here, there is a right-sided deviation of the trachea. The carinal angle still is fine, but I can no longer see the bronchial shadows. Bronchus intermediate shadow is not seen. And you see here, when you count 1, 2, 3, 4. Now you see here some rib is missing in between. There is an increased gap when compared to the gap here. See, compare it on to the other side. There is a distance between these two ribs is much more higher when compared to the distance onto the left side. So which means to say this rib is missing. And I can also see some organized metallic white shadows here, which means to say there has been a patient of pneumonectomy. Did you get it? And all volume loss is seen. So what happens? And you see here heart shadow is also present down onto the right side. So eventual tracheal pulling. See, why there is a mediastinal shift whenever there is a tracheal pulling? The heart pulmonary blood vessels are moving over the trachea on the right side. So that's the reason there is a pulling, right? That is what I was talking, eparterial bronchus, and I was talking about the structure of the pulmonary anatomy there, right? Do you remember that point what we were talking? So that's the reason whenever there is a tracheal deviation, there will also be somewhat mediastinal deviation too, mediastinal shift. Now you see here, how can I confirm that this is not atelectasis? First, bronchus shadow is not seen. Second, there is no rib shadow that is seen, and I can also see surgical clips, and I can also see that there is a tracheal deviation and mediastinal shift, eventual volume loss. But on the first 24 hours, it should be black. Later on, it should will become slowly white. Okay. See, eventual filling up of the fluid due to exudation. Okay. Eventual filling up of fluid due to exudation will cause the hemithorax to become more white. Okay. Fluid fillings will come over. Right. Did you understand, Benedict? Did you understand, Benedict? Is this clear? Okay. See here, in pneumonectomy patient, it gradually fills up with fluid. It gradually fills up with fluid, but don't ignore the fact of, don't ignore the, fact of, the pleural effusion here. Yes, filling up of fluid inside the pleural cavity is called as pleural effusion, but this is not filling up in the pleural cavity. This is filling up of fluid in the thoracic cavity because of the absence of the lung. So it doesn't matter even if I'm putting out 5 liters of fluid inside there also, it will not cause the tracheal shift. Get it? Is this clear now, Benedict? Density, yes, it will look white. Only in 24 hours it look. Shubham, the lung has already been removed. So why it is not affected lung? Lung is removed off. Lung is not even there. You get it? That is where you are confusing yourselves, I guess. The lung is not even present. It means to say no pleural cavity at all. Whatever that is left is there is only thoracic cavity. You got it? Benedict, is this clear now? Yeah, the fluid doesn't go anywhere. The fluid is coming down from other blood vessels, capillary fillings. Because of the congestion. Is that clear, Benedict? The fluid is completely present down in the open space there in the thoracic cavity. The fluid is not filling up in the pleural cavity. Pleural cavity is not there because the lung is not present itself. Get it? Benedict, did you understand now? Perfect. Okay. So that is how I am going to differentiate it. Right? Now, see here. That's the same thing. mediastinal shifts are also happening. Now you see here, the first patient what we were looking at, Mr. Smith, in that came down to the emergency department. Now look at this person. You see here there is a pulling up of the trachea onto the left side, and there is a opacity here, right? So that's why I say that it is the case of atelectasis, right? There is a shift of the heart and towards the opacification. Now it actually, we call it as atelectasis of the entire lung, right? And this one could be happening because of obstructing mucus plug, or you also call it as mucus impaction. And what is the most common cause for mucus impaction? It could either be bronchogenic carcinoma or it could be asthma. Get it? All the mucus producing, all the sputum producing persons, or let us say if the patient has been hospitalized and undergone a surgery under the influence of anesthesia, there is no gag reflex, so much fluid from the contents of the stomach entered down into the trachea, obstructing the bronchus eventually. So it depends on surgical history, it depends on asthmatic and infectious history with a productive cough, and that accidental displacement of the sputum down into the main bronchus, which is the most common cause for mucoid impaction, right? So that's the reason I characterized and I diagnosed my first patient, Mr. Smith, as atelectasis, but not pleural effusion, not bronchogenic carcinoma, not pleural effusion, or not pneumonectomy. Did you understand the differences now? Right? Is it clear, people? This is a very important topic. This can be asked for 2 marks questions and 4 marks questions. Write the differentiating features. What are the differences between, okay, what are the differences between pneumonectomy and obstructive atelectasis? What is the difference between obstructive atelectasis and pleural effusion? Okay, or what are the differences between, the only thing between the two is metal clips and absence of rib as well, Benedict. Okay, absence of rib as well. There is no rib shadow and also metal clips are present. Okay. Ha, Rich1, you are not even understanding. Pneumonectomy means to say I am removing the lung. So why I have to recover the lung? Lung is not even present there, man. Understand? Lung is not even present. Let us say, even if there is, let us say if I have done lobectomy. Okay, maybe, yes, Rejwan might be confused, but let us say if I have done only lobectomy, let us say I have removed completely, okay, I mean completely, you have removed the upper part of the lung, but still lower lobe of the lung is present. Lower lobe lung will actually eventually compensate, but all the upper part of the thoracic cavity where that upper lobe is removed, that will become opaque. Is it okay, Rejwan? Now did your question now get come? But required to recover the lung, you see, pneumonectomy is generally meaning to say removing the entire lung. Okay, removing a part of a lung is actually called as lobectomy, but time to require the lung actually depends on his pulmonary capacity and depends upon his underlying diseases. Okay, after pneumonectomy, how much time it is required to recover, it depends on the cause why the no lobe or the lung has been removed, and it actually depends if there is no underlying disease. Now let us say the other lungs can compensate, but if the lungs cannot compensate because the vital capacity and the total lung capacity has been decreased, so it generally takes something around like 4 to 6 months to recover. Okay, but still there will be respiratory distress, but still there will be chest pains. Okay, there is no complete recover and the patient does not. What about the space? Which space? It doesn't happen. Nothing happens to the space. The space will be left as space itself. It will eventually get fibrosed because the other tissues and the surrounding tissues, right, the thoracic fascias and other things, internal fascias and other things will eventually, like say the muscle things, pectoralis majors, all are other present there, right? The internal fascias will eventually and slowly start to fibrose. Okay, Nitish, is that clear? The rib must be replaced black. Why do you want? Why do you? Why are you really so worried about the rib when the lung is completely gone? You are so obsessed with ribs being replaced back. What will I do even if there is no lung? What will I do with the ribs? Ribs has got a function of respiration. When there is no lung, no respiration, what will I do even if I am replacing my rib back? Jerry? No regeneration? No regeneration. I am not a lizard to regenerate my ribs. Clear? Reshma, is your question cleared? We can't find them in the film because they have not replaced. They won't replace because we can't find in the film. No, it is not. We can't find it in the film because they did not replace it. And replacement is not necessary when there is no lung, no respiration. Ribs play a part with the internal intercostals and external intercostals, right? Yeah, I got it, Reshma. Right? Okay. Yeah. Yeah, that's a good reasoning. It won't regenerate. You need not even if you cut the rib, but still you need not replace it. Even if you are replacing, you are just giving out an extra organ. When there is no lung, what is the ribs going to do it there? Right? No form of respiration, so not necessary. Right? Is this topic clear? This is a very fairly easy topic. The next topic is atelectasis. You can easily understand it. So is there any doubt with your chapter today? Right? Tuberculosis, bronchogenic carcinoma are important essay questions. This topic can be asked as differences between the three things. Do not ignore this topic. So many questions can be coming down from here. Right? Anybody has any other doubts? Sir, how many ribs can we remove like this? Why are you guys so obsessed with cutting things and removing off? How many ribs? What difference it makes even if I am removing off all the 10 ribs? Huh? See, the thing is that to remove one rib, the reason for removing one rib is that I cannot pull out the rib from the space that is present down inside, okay, between the, okay, they want to become slim. There will be, yes, there will be a shape deformation. There will be spinal deformation. So that's the reason only one rib. Benedict, you got it very correct. There will be eventual kyphosis that is leading down because of pneumonectomy. And you see here, when there is a kyphosis, the other lung is already compensating when there is no lung, right? And when there is no ribs on present on the right side, let us say if I have removed the 10 ribs on the right side, what actually happens, the spine will eventually be pulled off because all the intercostal relations to the vertebra are removed, right? All the intercostal vertebrocostal relations and chondrocostal relations are removed. Then what actually happens? Hey, one by one, please don't spam. Benedict gave out a very good reason, shape deformation. Let us say I have removed 10 ribs on one side. Now, what actually causes? There will be loss of completely vertebrocostochondral relations on the other side. Lung is already there, right? Lung is already there, already gone. The other lung is already compensating. Now what happens is that the other lung will eventually, the internal intercostals now, sorry, since there are no vertebrocostal relations, the spine will start to bend, and as a result it will show up an influence on the left lung, on intercostal muscles as well. So respiration will be much more problematic. So that's the reason I will be removing only one rib. Did you understand it? So I'm not removing 10 ribs, or I'm removing of the entire thoracic cavity. Is that question clear? Right? Yes. And now, damage to the internal organs can also occur in case of trauma. What do you mean by that, Jerry? Why did you come up with that one there? Benedict made a very good observation. Cool. Right. Any more doubts? Okay. Right. Then tomorrow we are going to complete two chapters. We will be completing atelectasis and pneumonic diseases. Then I think we are almost done with complete respiratory system. Right. If there are no questions, I think this is where we will end our class today. Any other guys? Any other questions? Right. Sanitized, saturated, or you are sanitized? Well, if you guys are interested, okay, if you guys are interested, only after we complete our atelectasis and other major chapters, I will teach you the radiographic features of coronavirus. Okay, I will teach you the complete pathophysiological mechanisms of coronavirus, right? Because the confirmation of the coronavirus is done on a coronavirus pathological test. But if the pathological tests are not available, radiology is the only way of confirming a diagnosis of coronavirus, right? So better, since this is a very good time, we will learn about coronavirus also for knowledge purpose, not for exam though. Okay. Confirmation of a coronavirus is done on a pathological test. Okay. Kit immunoglobulin test, PCR, reverse transcriptase polymerase chain reaction, that is the confirmatory diagnosis. But if that test is not available, the progression of the disease and the effect of the viral load can be made by radiology. Chest CT, HRCT is the confirmatory diagnosis of progression of coronavirus. We will learn about that one also. So let us see you tomorrow. We'll complete off other chapters tomorrow. Okay, have a nice time. Bye bye. Right, I will ask Dr. Mo to upload the the video. Okay, just take some time. I think Dr. Mo will upload it. Okay, the people who had a problem with audio also will eventually try to get the uploads. Okay, sure, just take it some time. Also, you read down the slides as well. Got it? Anybody has a doubt, send me a message in personally. Okay, right, see you. I'll close up now. Bye bye.